Summers in 1994 was the one that first developed this. He called it a method without drilling, although you'll see there's a bit of drilling involved. But what we're using is an osteotome. It looks like a leather punch, and we're literally compressing and pushing the bone in. So it was a pilot study, and it reports excellent results, which means this is not a quantitative study. It's more like a technique paper. And they were lifting the sinus about 2 or 3 millimeters. So if we had 7, we might jump up to 10. And that's what an osteotome looks like. He was talking about using lateral condensing ones. So that means tapered. So again, if you imagine driving a wedge in, because it's tapered, it's pushing against the side of the bone as well. I'm going to explain to you why I don't like that technique, but we'll come up on that later. And they were adding bone. So they were using the hydroxyapatite, which is a xenograft, the cow bone that's been cooked at super high temperatures, as a filler. And they were using then something called a press fit implant, which we don't use today. We know that screw type implants are more successful, but this was maybe state of the art in 1994. So again, he did use some drilling. He did a 2 millimeter pilot hole just up until the base of the sinus. And then he would switch to these blunt tipped tapered osteotomes so that he could condense both the bone apically and sideways. And then he would add bone into that space apically. So looking something like this, where we have the tapered osteotome, and we push up and under and add the bone graft in this area. And conceptually, what we're doing is we're condensing this bone on the side. Now, if we're doing that, though, we're using higher forces, and we'll talk about what that means in terms of complications. So, was there any studies? As early as 1999, so this is around the same time that I decided to try this procedure, there was a study that had come out that followed 174 implants. And they didn't really have a standardized approach. They did mix the different implants. They used mixes of different bone grafts. But to be fair, this is a retrospective of a real-time practice. So, they're learning as they're going. But what they were able to show is that the type of graft, what they added, didn't make a difference. But more important was the base height of bone. So if the base height was 5 millimeters, they were showing a good success rate around 96%. That would be how long, surviving of the implant. And below that, they had 10% less success rate. Now, that became kind of the standard of care, if you would, for when people would consider using an osteotome procedure, and that is that 5 millimeter base height. You'll see that come up again and again in the literature. Now, again, there was a few other studies that came out in 2001, basically the very similar study with a 3-year follow-up showing 88% survival. So a bit lower survival here, but what they found and what's important in this, and I would completely agree with this finding, is that most of the failures are early. And what that means is we put the implant in and it's really not very strong. There's about 4 or 5 millimeters of bone holding it, and the rest of the bone isn't mature. And then you go and wear a partial denture or something like that, and you might move that implant and it becomes displaced and it fails. So that means it's failing before the final bridge is done. So in a way, that's good because we don't have big investment on the bridge work. We take it out, we wait 3 months, and we can do it over again. So the failures are easy to manage. So then there's this other study that wanted to say, well, what is the histology of this? Do we actually get bone if we're using this bone added technique? What does it look like? And so what they did was they looked at post implant survival, which around 95% was comparable to the other studies. And the histology, which means the cell structure and how good the bone was the same as lateral windows. So in other words, we have evidence from the clinical side, but also the microscopic evidence of the bone. And what they concluded was, again, when you have more than 6 millimeters in this case, and you're lifting about 3 or 4, that osteotome is the treatment of choice. So at that time, basically between 1998 and 2001, the evidence was saying 5 or 6 millimeters, you should switch to osteotome. And that was about the same time that we stopped using lateral windows in large numbers. Interestingly enough, when this number of 6 millimeters, though, they didn't actually give us any evidential data on that. I think that was more of their opinion. Other studies have taken a look at basically adding bone or not adding bone. In this case, we were finding that, again, if you have with a bone added technique using xenograft and autogenous, so this is kind of the standard of care now with a screw shaped implant in a relatively large number of implants, they were showing high survival rates. But if you take a look at their mean start point at 7.1 millimeters. That's a pretty good base height of bone. You could put an 8 millimeter implant in there and only have to lift one. So this is not a really big test of the implant. But if we look at the failures again, 10 of the 18 happened early. 3 more happened within the first year and a half. So again, the majority of failures are happening within the first year. And again, they also found that if the bone height was less than 4, the success rate dropped. And they had a reported rate of a 5% tear. So you can see by 2004, the tear rate had gone down. So what is the limitation? One question would be, how much can we stretch that membrane by pushing up? And so this was a very interesting study that looked at cadavers, because the conventional wisdom was 3 or 4 millimeters. And what they did was they looked and they found by lifting the conventional height, they had a 24% tear rate. Remember that we have other studies that report a 5% tear rate. But the thing is, you can't actually see the tear. We test it by something called a Valsalva. So imagine you hold your nose and try to blow. If air comes through your osteotomy, then you know you have a tear. But it's not like you can actually see the tear. And again, the critique of this, though, because that's a fairly high number, is that these are cadavers and they've been treated with formaldehyde. So the membrane is fixed. It's not flexible like a normal one would be. As well, there was no discussion about the shape of the sinus floor. And I'll show you a paper that we published later that talks about how the shape of the sinus floor is critical in lifting. So again, there are other variations. So all the way through the osteotome protocol was developing. People were looking at using different types of implants, adding or not adding bone, how much degree of drilling we're doing, or trephining a core up into the space, or using a multi-staged approach where we do two osteotomes instead of one. We're going to go over some of these variations for you. So the first one was the use of a screw type implant. So in the early 2000s, we had a shift away from press fit to threaded style implants. And that was based on the strength of Brunemark's data, much, much better than press fit designs. But then by, again, that time, 3i had developed the first micro-etched surface, which allows better fixation of the bone. And this is kind of close to the current surfaces we're using today, where we have micro rough surfaces. And the other thing that they suggested is the screw itself acts almost like a hydraulic lift, and you can get additional lift by the placement of the implant. So you're not just relying on the osteotome, but the additional lift from the screw. There's other techniques. Early in 1994, this Toffler had described displacing a core. So you drill with the trephine, which is basically a hollow round drill, and it creates this weakened core, which you can push the core up and then backfill this area with some bone. And so again, that was more like a case series, so a descriptive paper. And then there was another paper that evaluated success rates with that. And what they found is roughly 2 out of 3 times they would get a pretty good lift. Maybe 20% or less, they wouldn't get much lift at all with this. So then there was this idea that maybe we don't need to add bone. And this one really enticed me. I found this to be very interesting. This was done using lateral window procedure. So just like the earlier procedure, we showed you lift the membrane up and pack bone in. What if we lift the membrane up and just put implants like a tent post, and then just close the membrane and see what happens? And what they found was, even without adding bone, the bone would fill up into that space and they would get good implant survival. So just like this tent is held up by those posts, the membrane, all you really need to do is create the space and the bone will fill back in. And so with that, we move on to doing the osteotome procedure without adding bone. And so one of the first descriptions of that was in 2010, and they found no difference in implant success and that bone did fill spontaneously. And that was exactly what we had discovered in our own protocol. So a guy named Rabdar Nadir was starting the first prospective study on this. And what he was doing was looking at using that with the osteotome approach without added bone. He categorized the type of bone to start with. He categorized the mean residual bone height. So this was a very well done study. In fact, this one won the award at one of the meetings when I was at the osseointegration meetings in Europe. And I got to know Nadir because we were actually publishing our retrospective data in sequence at the same time that he was publishing this. And so what he found was basically 96% implant survival by 3 months by testing them with a torque, and by 1 year they were all functional. And his average gain was about 2.5 millimeters. So, going from a base of 5.5, adding 2.5, he's getting to an 8 millimeter implant basically, or even in this case, 10 millimeter. So why do I don't add bone? Well, one reason is it adds cost, and I'm trying to make things cost effective for my patients. And the other thing is you can't ever really know if you have a tear. So if you do have a tear and you don't know that, you might be displacing a foreign object into the sinus, and that's going to give you some longer term complications. Again, what is the tear rate? We know from clinical study it's 5%, from cadaver it's 20%, and depending on your skill set, it could be anywhere in between, because this is really as much art as science. An osteotome procedure is a lot of feel. I teach this to the grad students at UBC, and it's something that's hard to teach because every case is different. Sometimes you use high forces with the mallet, sometimes less, sometimes more pre-drilling, sometimes less. So it's a really tough thing to teach, and therefore, when you're learning, you're going to have more complications. So the question is, can we go beyond a 3 or 4 millimeter lift? One thing we do is, if we consider that we have, say, 3 or 4 implants beside each other, we're lifting that membrane in sequence like a tent, and we can get more lift. Or the shape of the sinus, and this is something that we've investigated later. If the sinus itself is concave, when you're lifting it, you're not stretching it, as opposed to if it's flat, you're tearing it. So again, can we also lift it twice? So do the osteotome, gain 3, do it again and gain another 3. And yes, that's possible. Or we can also even use an endoscope inside the sinus. Now, we don't do this, but it was published showing that that's another way that you can lift it to the maximum. And when you see the tear kind of starting, you back off a little bit. So that's an interesting technique. So here's what I mean by multiple tenting. If we look at this, this is about a 2.5 to 3 millimeter residual bone height. And we were able to get to 8 millimeters because we tented the membrane across using both implants. So what are the complications? Well, one is the loss of the gain of the bone. In other words, that bumping up of the bone, does it fall back? Infection, something called BPV, which we'll find out, and just regular implant failure, the loss of the implant. So Brager in 2004 published that using the Summers technique with added bone, in that case, BioOs, which is a xenograft, they started out with 7 millimeters. They gained 1.5, but what they said is by the time a year went by, they only held about 0.3 millimeters of their gain. And so they said, since most of that bone gain is lost, it was questioning it. But at the same time, the study did find that they could allow to use longer implants. Well, the conclusion here is kind of flawed, and I'll show you what I mean by that. They were measuring the bone beyond the end of the implant. So let's say that you have a tent and you put a post up and you put the tent on top. You don't expect the tent to stay above the post. So what they were doing was measuring the bone that was pushed ahead and then measured the loss until it hit the top of the post. So here, for example, you see the bone pushed way ahead. Now, I don't need that bone there because it doesn't provide any function for the implant. And sure enough, if I look at that, it goes down to the point where you get to your functional effect of the implant acting like a strut. So this bone is important, but that bone isn't. And so that study that said we lost 20 or 80% of our bone was measuring something that didn't really matter. So again, the bone drops to the apex and it stays there. Here's another example. We see pushing well beyond. Again, this is a nice shaped sinus, concave floor, very easy lift. And we see that finishing at the top of the implant. And that's very normal. So as long as it stays at the apex, you're fine. What about BPV? Well, we're using a hammer and we're tapping and we're using these devices to compress the bone. And so there are a few case reports, and there's not many, but there are some that people get dizziness after that. And because there's something called an otolith, which is a stone inside your ear. And that is, if it's on a hair and knocked loose, it bangs around inside your balance apparatus and makes you feel dizzy. Now, there is a technique that physiotherapists can use called the Epley maneuver that helps drain that stone out. But in my opinion, it relates to mallet forces. We've never had a case of this develop, and we've done over 1,800 of these procedures. Besides that, there's never really been any report evaluating that in consecutive cases until actually the paper that we had published a couple of years back. So this is how you limit the risk. Do you see these osteotomes are parallel walled? They're not tapered. So again, if you're jamming a wedge into something, like imagine jamming a nail into wood, that point of the nail is compressing and you have to use force. This isn't compressing the lateral wall, so we're using only the force to push the apex up. We're not wasting any of that energy on the side compression. So that actually gives us much less forces involved. And as well, we can vary the amount of drilling we're doing. So we might use the drill a little bit more to width increase before we switch to osteotome. So this is where the technique side becomes more art than science. So how about infection? Well, infection is rare. Like we've had now in 1,700 cases, consecutive cases, only one infection. And we know that penicillin might be a risk factor, but in that particular case, it was a history of chronic sinus infection. Remember, though, that we test patients for this. So within that 1,700, we would have had very few that were truly allergic. But even with an infection, it's easy to resolve. And why do I say that? There's no bone graft that you have to go and remove, so there's no foreign object. And there's also no large flap. Like when you do a sinus lift procedure, you're opening up a very big space between the skin and the bone. And bacteria love spaces. With this procedure, it's a very small elevation, so we don't have what we call space infection risk. So this was our one complication. This is the implant in place. You see what I mean about the very small elevation, maybe a couple of millimeters on either side. And what we did was we actually took an x-ray to see whether we were in the sinus per se, and you can actually see the bone and the membrane bridging over top of the implant. So the infection was not related to the implant causing anything. It's just that this particular patient had a history of sinus problems, and we stirred it up. So what about failures? What about the loss of the implant? Well, early on, Petrushin reported these 6mm implants had a high failure rate of 47%, especially if we have low residual bone height. So there's our number again. This would be too low of a number to be worth doing. But I disagree with this paper because the number of 6mm implants in this study, I think it was less than 20. And when you look at the pictures of the cases, they were situations where there might have been 4 teeth being held by one implant across a long bridge. And it's asking a lot of a short implant. And our data conflicts with this. We had a much larger sample, I think by a factor of at least 10. And we have very specific loading protocols so that we wouldn't put a situation of a long span on a short implant. And we'll go over all of those towards the end here. So what is my protocol? Well, I start with a 2mm pilot, and I will drill within 1 millimeter of that space. And if the bone is very low density, I might not use the drill again. If the bone is high density, I might actually increase the width here so I'm not pushing as much density into the bone. But that's the technique side. Then we use a small bullet-tipped punch, and we literally will make an indentation that's only about 1 millimeter deep into the bone. And what that does is just like when you have a cardboard box, if you bend it, once it's got the bend going, it starts to move a lot easier. So then we use these straight-walled but concave tipped, and we go each one increasing in size. And you can see that goes from, I think it's 2.8, 3.5, and 4 in terms of the width. And then finally, with the last portion would be the implant doing the last lift. Now, the thing is, if I'm going to go to 8 millimeters, I'm not going to go to 8 all the way with each one. I'm going to go 6, 7, 8. So each time I'm going wider, I'm going a little bit taller. So I'm gaining height sequentially. And that way I'm not putting as much strain on the membrane because I'm getting wider. The lift is happening further out. So that's, again, cartoon form. But there it is there as an example of the lift once we've completed. So again, only use straight-walled osteotomes unless you want to create higher forces and maybe risk upsetting the balance canals. And if you are using short implants, we always splint them. Basically, the idea would be 1 implant per tooth. So how does this compare generally? Well, if we look at the systematic review of lateral window, the average, and this is from the guys that wrote the book on it pretty much, the average is 92%, let's say. So implant survival, 92% if you do lateral window. Osteotome, we're going to look at our numbers, but we're close to 98.5. So less risk procedure with a higher outcome. So here's another example. That's the one we just showed you a minute ago, 5-year follow-up. There's the 3 months, the 5 years in function. Again, you can see that bone just kind of sitting right up over the top of the implant there. Oh, and notice that they are joined together. Absolutely critical. We'll finish on that note. So this is what the procedure looks like. We do a starting point with the round bill, the 2mm twist, and we move on up. So I'm going to show you what that looks like. There's our 2mm twist. There's our bullet punch. There's our first osteotome, our second osteotome, and then the implant goes in. If we're going to a 5, we might have done one more osteotome. The procedure itself is very quick. I would say much faster than a lateral window, maybe a third of the time. So we published one of the largest studies on this paper. It's a retrospective. We collected factors like what was the patient's health status, the type of implant, torque on insertion, how stable it was, how long it took to load. We looked at whether we did joined or unjoined, cemented. And then we looked at things like implant failure, how well the bone stayed, and then complication rates. This was the paper that was published in IJPRD. And again, you can see that our implant survival rate was 98.3 at the 5-year, and that was on 926 implants. So that's the breakdown of the cases. But what's important to note is that we had very low bone height, so low residual bone height in a large number of cases, 209 that were below what would be considered the standard. And again, this is a good example where there was 2 millimeters of bone here. But again, each implant joined together so that we have that good force distribution. And this is a 5-year outcome. Another 5-year outcome. And this is a good example of the multiple tenting effect. You can see 2 millimeters of bone, maybe 3 there. And we have that tenting from each one. So we could lift it higher than a conventional lift. And here's the actual survival rate. Again, if we look at the conventional height of being 5 or more, very successful, well over 98%. And 5 years out, we might be closer to, say, 96 or something like that, with our residual bone height being below standard of care. So this has really changed where I don't do that many lateral window procedures. So again, here's our own data on it. Basically, we had 1 infection, as we showed you already, 0 cases of vertigo. And then I reworked the data and I said, what is it that makes my selection category to do certain procedures? For example, would I do a single implant lifting that much in that area? The answer is no, because it's a flat floor. You can't just lift it that much. Whereas a concave floor, you can lift it much more. So what we looked at is the effect of tenting and the effect of the concavity as well as residual bone height. So kind of reassessing what are the factors that make this a decision point. And what we found, well, this is our distribution of cases where we had the different shapes and sinuses and the residual bone height in this case with down to 2 to 4 millimeters of residual bone height. And what we did find was absolutely the data was correct that residual bone height is the most important thing, and it made a big impact on success rate. But even in if we're looking at 2 to 4 millimeters, we had 5 failures out of 92. So let's say that's around the 92 or 93% survival. That's at least as good as lateral window. So even in short bone height, the survival rate was better than 94%. And I think that's pretty impressive. Now, we have to talk about informed consent with patients because this is not standard of care. But at the same time, if I were to tell you I could do this, or you could have your sinus grafted with bone, most people actually choose this. The other thing that we found was there was an impact on sinus shape where the concave was the most favorable because, again, it's inverting. It's a very easy lift. The septa was very successful. That's where we're drilling the implant into that ridge that we talked about. The septa looks like this, that little spike in the bone. We don't need a big implant because the septa itself is very strong. So it was quite high success as well. The more difficult one is a flat floor. Again, so if it's flat and you're lifting, you're going to get more risk for a tear. And we did find a tenting benefit. So when we have single versus multiple, multiple sites had roughly double the success rate of a single. So again, here's an example of a very flat sinus floor where we're going to go ahead and do some osteotome procedure. And you can see we did the side-by-side lift. And there we are. We actually, in this case, because we had a strong implant in this area, and we had 3, we did an immediate temporary crown. So this is, you know, something that maybe it would be a bit more experimental. And we have 8-year outcomes that look like that. So how much distribution do we get? If you look at it, most of our lift was 2 to 3, like the conventional literature says. And when we measured that, we're not talking about this. I'm not going to call this a 5mm lift. I'm going to call that a 2 because it's to the end of the implant. And we had this number that was splinted. So we were very heavily biased towards joining implants together. These would be situations where there would have been one tooth, like a single tooth space. And this was a situation where the lab made a mistake and didn't join them together. But you can see that we're gaining between 2 and 4mm on most cases. I won't bother going too much into detail about the implant type other than to point out that we had at least 200 and something implants that were then considered short. By today's standard, 6mm is short though. So what is the outcome? We have a 1-year survival of 98.8, a 5-year of 98.5, and a 10-year of 97. These are the implants staying in bone functioning. We have bone scores. Now that's what we're looking at, bone loss over time. And even at 3 years, we still had 96% that had less than 1mm of bone loss over time. So very low rate of gum disease or bone loss projecting over time. Infection, as we mentioned, was 1 case. And we had, though, often enough to have to delay. So at the 3-month point, the implant would move ever so slightly when we load tested it. And what we would do is wait an additional 3 months for that bone density to increase. And all 5 of those did recover their stability. And again, 0 cases of the benign paroxysmal vertigo, which is a dizziness. So again, here's another example, very, very short, less than 2mm, a 4mm lift. And that is the same case years later. So let's just take a look at that. What are the risk factors for failures? Well, if we look at the failures that did happen, 80% of them were before the crown went on. And that is literally because the implant, if we go back to this picture here, you can see that that implant has not got a lot holding on to it. It's just got a couple millimeters. And so it's literally just kind of like that. And if it takes any bite pressure, someone biting on a carrot or wearing a denture, it's going to get moved. Only 20% of our failures happened after crowns went on, which is great. Now, this is, although still early because it was about a 1 to 5 year study mostly. I'm going to show you later on, there's some different numbers over time. But the ones that did happen of these basically were the 6mm implants with very low density bone or banging around under a denture. And I'll show you what I mean. You see that the wear on this post, that shows you that there's a lot of pressure. And if you look at a case here, we did an osteotome at the back and that implant failed. It's a short implant, but look at the denture was relined and we can see the liner was actually directly hitting. It should have been cut back more. The way this was cut back, it should have been cut back completely so there's no pressure on the implant. So that's a bit of a shared failure between the restorative dentist and ourselves in not communicating. So if we have that low density bone, is there a way of making it more dense? One way is this reverse cutting drill. So instead of drilling forward and spinning all the stuff away, it drills backwards and pushes the bone in against itself. So I've done a few of these cases. I would say somewhere less than 40 or 50. But it is an interesting protocol and the end doesn't cut. So you can, in theory, push right up under and not tear the membrane. That's reportedly. So this is the kit, what it looks like. And you go through first with a very narrow tip and you keep increasing as you're condensing the wall going out. So that was one of our cases and that one was a success. So then we tried it again on a different case. And in this particular case, we did our densification, but perhaps too much, because what we got here was what's called compression necrosis. So there's too much compression of the bone. So that was a failed implant. And then we did another case here where the bone was very low density. And you've seen before when I do the osteotome how the bone is pushed forward. When you're doing the reverse drilling technique, you're not getting bone pushed forward because it's being washed away by the slurry. So you end up with almost nothing on the end. And we had in this case an actual tear that developed we hadn't even realized, and the slurry was filling up the sinus. And so I don't think that the case is without learning curve. And although the implants were successful, we don't see the bone over the top the way that we would really like to. Although, again, you can see here, we're just barely beyond the bridge of the bone. It's not my favorite case. It's successful, but it is something, again, something to learn. So again, here's one of the last cases I'm going to show you. This was someone who was on a blood thinner that was not a good candidate for doing a lateral window procedure. And yet we had 2 millimeters of residual bone height. And what we did was first do the osteotome with only adding bone. You can see right here and right here. And then we closed it up and waited. And then we did it again with the implant, gaining again another 3 millimeters to get to standard dimension fixtures. So that's the staged approach. So again, there's lots of variations with these techniques. And that's the same case over 3 years now. So I'm going to just add one word of caution. So we're done with the presentation. Hopefully you guys enjoyed that. The word of caution is that the longer we follow up, the more we see failures. And it's just a fact. But where do the failures come from? There's 2 areas. By the way, this paper was literally just published like this week. So post-prosthetic, that means after the implant crown is finished. Notice now that that's the highest number. Now, we're not talking about just osteotome procedures. We're talking about every single implant that we've done over the past 20 years or so. But what we're seeing is that some of them, there are more failures happen as time goes on, and they're happening with the crown and bridge in place. And if we look at that, at least a third, so 1 out of 3 of these failures is coming as what I call a sudden unsplinted or sudden load failure. So the implant's happy in bone, everything's fine, and then one day it just overloads the bone. And that is something that we do see, particularly with single molars, back molars and bruxers, and this area right here, the short bone height group. So the osteotome group. Now, the question is, would we see the same with a lateral window group over time? I don't know. But what I do know is that I would be looking at these cases and managing their load. So always, again, splint posterior implants. Again, we can't forget as well, periplantitis. You can go on our website. I have a 3-hour lecture series on periplantitis if you want to learn about that. That is still the most common cause of implant loss. And it's typically associated with some risk factors, gum disease history, autoimmune, smokers. But I'm going to be putting on another lecture series soon that talks about load risk and late stage loss and show you the literature and the science behind that. And with that, I will thank you. Hopefully the grad students got something out of this. In summary then, no added bone osteotome procedure is very effective. And if we have RBH greater than 5, it's not only more effective and cost effective, it's less risk. If we have RBH between 3 and 4, it has fairly good survival rates and is still, again, much less risk. The guidelines in general would be 2 millimeters is possible, but I think you should consider that experimental and inform your patient. Between 3 and 4 millimeters is certainly adequate if you're joining the implants together or you're starting with a concave floor. And certainly anything from 4 to 5 and up is absolutely standard of care these days for doing an osteotome procedure. And once again, always splint your posterior implants if they're adjacent to each other. And feel free to visit our research section on the website. The original articles that I've quoted here are there, I think, in full PDF form, so you have access to them. And with that, I'm going to end the show. So I'll say stop share and thank you.